Good evening. Welcome back to my Avivences. Let us know if you can hear us loud and clear. I am back with Dr. Roy Pascal Naja. You can see him right here. And I'm glad that we are having you today. This is an interesting topic that we are going to discuss today. Roy, how are you feeling today? Are you ready to educate us a little bit more on non-invasive prenatal testing and share your experience and also, of course, your insights on this as well? How are you?
Good, good, and of course, ready to always educate,
That's good.
Caroline.
Thank you so much, and welcome everyone to our topic today. I know this is something that we haven't discussed in a while, actually. We did a topic on this already. However, this is still something that we haven't explored thoroughly. So I'm glad that we are going to talk about it. And of course, we have our guest who is actually director of Eurofins. So this is a genetic testing company. And of course, Roy will definitely speak a little bit more on this as well. So please let's start with the presentation. I guess we can go ahead with this. However, before we start the presentation, remember that there will be time for your questions. Roy is here for you. So if there are anything, if there is anything that you are wondering and you are not sure about, or simply would like to ask anything, Roy is here for you. So after the presentation, you can type the questions or you can do it during the presentation and Roy will definitely take care of those for you. And I guess we can start with our presentation. Roy, let me know if you are ready. But first, if you can briefly introduce yourself, that would be great, so everyone can see you properly and can find you.
Perfect, perfect. Thank you for this generous introduction, Caroline, as always. Uh, Good evening, everyone. Thank you for joining. My name is Roy Pascal Naja. I'm the laboratory director of Eurofins Clinical Genetics here in the UK and also the chief scientific officer of Eurofins Clinical Diagnostics here in the UK. And here we go. The topic for this evening is a non-invasive prenatal testing following IVF or IVF in combination with PGTA. Is it beneficial or not? Right. We will be discussing trisomies, their importance in pregnancies, a brief history of how prenatal screening for trisomies started and some, you know, important time points. What is non-invasive prenatal testing? Is non-invasive prenatal testing recommended following IVF? And last but not least, is an IPT recommended following IVF and PGTA? So we will discuss these topics in detail. And we'll start with a bit of a refresher on us humans and chromosomes. Well, we humans have chromosomes, and chromosomes have our genetic material, everything about us. We have 22 pairs of chromosomes, numbered 1 to 22, and an additional pair of sex chromosomes. As you might know, XX is for females and XY is for males. Now we normally inherit one chromosome from each parent, and this is transmitted either through the sperm or the egg. However, this process of creating the sperm and the egg is not foolproof. Errors could happen, and this could result in what we call a trisomy. One of these cases would be, for example, an egg that has been produced with two chromosomes instead of one, that fuses or is fertilized with a normal sperm that has one chromosome. The resulting fetus or baby is going to be a trisomic. It will have three chromosomes and not the normal two chromosomes. Now, why are trisomies important in pregnancies? Well, the most the most uh, relevant cause of miscarriage uh, in pregnancies is due to chromosomal abnormalities, and most importantly to these trisomies that fall under the category of chromosomal abnormalities. And this is a graph I took from a very, very important piece of work published back in 2001 in a very prestigious paper, Nature Genetics or Nature Reviews Genetics, by the group of Hassold and Hunt. The y-axis is, you can't really see it here, but the y-axis is the percentage of trisomies. The x-axis is maternal age in increasing order. You can clearly see increasing percentage of trisomies among clinically recognized pregnancies with advancing age. You can clearly see. And then more than 25% of clinically recognized pregnancies are trisomic in women above the age of 38. More than 25%. Now, obviously, there's not, there's not that many, people born with trisomies. The majority of these trisomies will result in a miscarriage. So nature has a way to take care of these abnormalities, and it is, through a miscarriage. But we all know that this is not always the case, because there are certain trisomies we call the common or relevant trisomies will result in the birth of a child, and sometimes, well, not sometimes, with an adverse outcome. So trisomy 21 leads to Down syndrome. And now modern science, with the help of modern science, a child born with trisomy 21 could grow up into adulthood and could have a more or less normal life. But this is not the case for the more drastic trisomies, those for trisomy 18, which cause Edwards syndrome, and trisomy 13, which cause Patau's syndrome. These are more detrimental. The baby or the fetus or the child dies in utero or at birth or just after birth. And there are only very rare cases where a child goes up to 1 year of age. I've included NHS links to these trisomies, and these links are very, very helpful, especially to pregnant women and especially to pregnant women seeking some sort of screening for trisomies. Now, how did this start, this history of prenatal screening for trisomies? Well, ever since we recognize that trisomies are important, and this, goes back to as old as 1959, where a scientist called Jérôme Lejeune discovered that trisomy 21 is the genetic reason for Down syndrome. Then just the following year, what happened is that a screening program was launched for Down syndrome, and this was based only on maternal age. So call it crude, call it rudimentary, yes, but back then it did offer some clinical utility to women and managed their expectations. Now, nothing really happened until the 1990s, when the gold standard test that is still used nowadays was launched. This is the first trimester screening for common trisomies, your 12-week NHS scan here in the UK. And it involves taking into consideration maternal age, measuring some serum biomarkers, and the knuckle translucency of your child, which is the thickness of the neck by sonographic measurements, and calculating or giving an estimate of a risk um, to the pregnant patient. And this has benefited a lot of patients and has been used since the 1990s and is still used nowadays. Now, in 1997, there was another big breakthrough when scientists discovered that there is pieces of genetic material floating in in the maternal blood of a pregnant female, and the origins of these genetic material is the fetus and not the and not mom. So this was a major discovery. It took, though, 15 years to develop a test and apply it clinically, and this is the non-invasive prenatal test. And unfortunately, here in the UK, it took the NHS another 9 years to implement this, and it's not offered to all patients. Only only patients that are deemed at high risk after doing the first trimester screening test. Now, NIPT, non-invasive prenatal testing, uses a sample of maternal blood to check for trisomies and other defects in the fetus. Now, we said that thanks to this group in 1997, they recognized that there's fetal DNA in the peripheral blood of mom. And what is the source of this genetic material? Well, the placenta. The placenta. The placenta is composed of different types of cells. Some of them are are fetal of origin, other maternal of origin. One of these cells, certain types of these cells called trophoblasts, they die, and this is a normal biological phenomenon. But once they die, they release this genetic material into the bloodstream. And this is how we're able to pick up this genetic DNA or this DNA or genetic material coming from fetus to be used in an IPT. Now, this is detected as early as 5 weeks of gestation, but the concentrations are only high enough beginning week 10 um, and onwards in order to be compatible with the NIPT test. Now, types of NIPT, there's more than one type of NIPT. You've got your basic NIPT, which is the test that screens for the common chromosomal trisomies, T21, trisomy 21, trisomy 18, and trisomy 13. Now, expanded NIPT is an NIPT test that checks for abnormalities in all of your chromosomes, including your sex chromosome and all the autosomes or chromosomes 1 to 22. In addition to that, they will also detect certain segments of these chromosomes if they are lost or gained. So it's an expanded NIPT. Now, technology advanced and allowed more advanced NIPT tests uh, to be available, and these include expanded NIPT plus much more. And you can go on to our website, prenatalsafe.co.uk, and discover all the different options of NIPT available for you. So, to whom should we offer NIPT? Well, to all pregnant women. This is not me saying this. It's in the guidelines of several national societies, like the Maternal and Fetal Medicine Society, the American College of Obstetrics and Gynecologists, the American College of Medical Geneticists. Uh, yes, to all pregnant women. But it is highly recommended to women of advanced maternal age. Remember at the beginning when I showed you the curve where the trisomy shoots off um, in the curve for females, pregnant women after the age of 35. Repeated miscarriages, patients with repeated miscarriages and patients with previous trisomic conceptions are considered at high risk, and NIPT is highly recommended to these patients. Now, advanced maternal age and repeated miscarriage, these are forms of infertility, right? When advanced maternal age also leads to infertility. And repeated miscarriage is a form of infertility. How do we treat infertility? One of the ways is in vitro fertilization. Again, IVF or in vitro fertilization aims to treat infertility. And this has been very, very successful. And this has been applied for several decades, ever since the birth of the first IVF baby, Louise Brown, back in 1978. And over the years, the IVF field has advanced and has helped a lot of couples achieve pregnancy. So it and it is able to treat infertility, and it uses the main thing in IVF is, well, IVF is to create an embryo in a culture dish and grow this embryo to a certain stage and look at its morphology. And if it's a good looking embryo, then the healthcare professional or embryologist will transfer this embryo. So morphology is very important, and it's the basis of embryo selection. Um, this is how IVF started. Then after morphology, morphokinetics, or we had instruments called time-lapse monitoring instruments that look at the embryo, at the development of the embryo in real time. So it's in the culture dish at day one, it's being recorded overnight to day two, to day three, to day four, to day five, and we know what must happen during these critical first 5 days of life. And this is how we measure morphokinetics. And now the embryologist looks at both morphology and morphokinetics and makes a decision as to which embryo um, is to be transferred. Okay, uh, this is all good, and again, it helped many couples achieve a pregnancy. However, it's very important to know that both morphology and time-lapse monitoring or morphokinetics is not capable of predicting a trisomy. This has been published more than once, which means that an IPT is highly recommended to IVF patients, especially in the AMA, advanced maternal age category. Now, pre-implantation genetic testing for aneuploidies. What is this? It is, in fact, an early stage of an IPT applied to the pre-implantation embryo, very early. Um, what happens is that the embryo is created by IVF. It's grown in a dish to day 5, and then the embryologist takes a piece of the outer shell of the embryo, and places it in a tube, sends it to a specialized genetic laboratory, and PGTA is done. Now, how is PGTA done? The exact same way as an IPT, or expanded, and specifically expanded NIPT. So PGTA looks at full and segmental chromosomal abnormalities, whole chromosomes gained or lost, and even pieces of chromosomes that has been gained or lost, using the same technology as an IPT. So transferring a euploid embryo, which is devoid of a trisomy, tested by PGTA, and achieving a pregnancy puts the patient at very low risk. So it's a beneficial thing. And this has helped patients with repeated IVF failures, repeated miscarriages, achieve a pregnancy. Is PGTA foolproof? No, nothing is foolproof, unfortunately, and there's always possibility of error. Now, we always have human error, although unlikely nowadays, but you still have the chance, a very low chance of sample mix-up. Also, you can have contamination in the sample. And there are certain basic PGTA platforms that cannot detect contamination and are affected by contamination. And um, this contamination will obscure the result and end up in giving a false negative result. Last but not least, mosaicism. Mosaicism is a biological phenomenon that cannot be circumvented. This is an embryo, a mosaic embryo, meaning that the embryo is composed of two different types of cells: normal cells, the blue, and trisomic cells, let's say, the red. Now, as I showed in the previous slide, with PGTA, you take a piece of the embryo, and if it happens that if you take a piece of the embryo where the cells are normal, like this one, then you'll get a negative result, right? With PGTA. But if the embryo is predominantly or grows to predominantly have trisomic cells, then you'll end up with having a trisomic child. So this mosaicism is not um, very, we thought at the beginning that it will cause a big problem, but there's now it's more believed now that it's not as drastic as we thought, but still it is a possibility to have a negative result with PGTA, but the embryo or your child being also still trisomic. So that's why I looked back into the literature and to see has anyone looked at an IPT following IVF and PGTA? Were there any published studies? I found only one by a very good famous group, and this was published in 2020. And what this group did, they looked back. So they did a retrospective study. They looked back at 1,139 patients that underwent IVF and PGTA and had a euploid embryo transferred, which resulted in a viable pregnancy. Now, this pregnancy was an ongoing pregnancy, and after 10 weeks of gestation, an IPT was applied to these patients. Now, 1,131 patients still had a negative result, concordant with the PGTA test, but there were 8 of these patients that had a positive NIPT result. After having any screen positive result, you need an invasive confirmatory diagnostic test. In this case, it's CVS or amniocentesis. All of these 8 positive NIPT result patients went in and had an invasive test, and only one of them had the case of chromosomal abnormality confirmed. So um, this means that the positive predictive value is 1 over 8 or 12.5% for an IPT applied to patients that had IVF in combination with PGTA. What does PPV mean? PPV is positive predictive value. In a nutshell, if you get a positive result with the NIPT test, how likely is it that you will have a child with a trisomy? Or how likely is it that you will have a confirmatory diagnostic test, amniocentesis or CVS, showing that there's trisomy? In this case, it was 12.5%. So there was 87.5% false positives. Now, if this couple did not do an IPT, this one case, it would have been missed and it would have resulted in a in an aneuploid or abnormal child. Now, is this warranted? You know, it's uh, is 12.5% acceptable? The same group the following year released another review discussing the same matter, and this is summarized here in the key points. Um, they concluded that although PGTA is highly utilized for the selection of euploid embryos for transfer, the possibility of error exists, and therefore the NIPT should be offered to these patients. Now, if patients who undergo euploid transfer with IVF and PGTA have a positive NIPT result, they should be informed that PPV of NIPT in this setting is likely to be lower. As long as you properly counsel the patients that had IVF, had PGTA, result was a euploid embryo, transferred the embryo, had the pregnancy, then had an NIPT, but had a positive result. As long as you tell the patients that there's a big possibility that this is a false positive result, um, I think and this group believes that there is still clinical utility for offering this test because the study cohort was only 1,139 patients, as I showed in the previous slide. This is quite small, so we need bigger studies in the future to really calculate PPV. But still, there is a chance, and an IPT, I believe, is still warranted. So, and the most important thing is to know that always, in any type of screen positive test, you will have to have a diagnostic confirmatory test. So if you have a positive and IPT result, regardless whether you achieved this pregnancy naturally or you went through IVF, or again, IVF and PGTA, you need to have a confirmatory CVS or amniocentesis test to confirm this result. In summary, trisomies increase with increasing maternal age. NIPT is highly recommended for the IVF patient population, and NIPT should still be offered to IVF/PGTA embryos transferred and achieving pregnancy, but the positive results should be interpreted with caution, and proper genetic counseling should be offered. Thank you. I think now it's time for questions.
Yes, it is. Thank you so much indeed, Roy, for introducing us to NIPT and, of course, explaining whether it should be with IVF or IVF with PGTA, and, of course, whether it's also someone conceived naturally. So that was a very interesting presentation. Thank you so much for bringing this topic to us as well today. And you're right, it's time for your questions. There are 2 questions ready, but I'm sure there will be more. So if you have anything that you would like to ask, this is your time. Roy is will help you out with anything that's on your mind. So let's go ahead with the first question that we have here. And let me just go here. Here's the question. So is the prenatal test using circulating fetal DNA done by NGS, as in PGTA using trophoctoderm biopsy, or is this done in using a different technique? And if you can tell us more about the costs as well. Thank you so much.
Very good question. As I said, yes, the test, there are more than one test of NIPT. The most the most widely used one is a test from a company called Illumina. And this is really has become the gold standard test, and it uses NGS, and it's basically the same test as the one used in PGTA. Now, the cost is something that I cannot answer. Uh, Many different clinics offer different cost. Some clinics offer an NIPT test coupled with an ultrasound, because doing an IPT you should have an ultrasound, or you should have had an ultrasound, because it's important to tell the NIPT laboratory whether it's a singleton or a twin pregnancy, and there are a bit more features,
Mm-hmm.
more information that we need, and you can only get it from an ultrasound. So I always recommend having an ultrasound before coming for an NIPT test, or doing it at the same time.
Mm-hmm. Okay. Thank you, Joseph, for your question. And let's go to the next one, short one. So, can the NIPT test be wrong?
Thank you, Ella, for this question. This is the most common question that I get. The most
I'm
common
sure.
question that I get. And it's a very important question, because if you go online, you can find so many different companies, so many different clinics, so many different testing laboratories saying my accuracy is 99.99%, mine is 100%, specificity, sensitivity, and it's all misleading. Uh, I, I believe that the 2 most important parameters you need to ask the laboratory is positive predictive value and negative predictive value. So once your sensitivity and specificity is very important, but when you do the test and you get a result, then you need a good metric to manage your expectation. And this metric is positive predictive value, like I explained before. So
Mm-hmm.
what are my chances now of having um, a child that is truly trisomic? So a test that has, and positive predictive value is affected by sensitivity and specificity, but also is affected by low and high risk patient groups. And the most important of this is patient age. For example, a female aged 20 had an NIPT test and came back with a trisomy 21. The positive predictive value, let's say, of this platform for trisomy 21 is only 70% at her age. So there's still 30% chance of false positive. But a female aged 40 using the same test, the same laboratory, comes back with a trisomy 21. The positive predictive value in this case is 98 or 99%. So always ask about positive predictive value when you have
Mm.
the test and when you get a positive screen result. Now, when you get a negative result, then you need to ask about negative predictive value. And almost all platforms have more than 99.9% or 99.99% uh, negative predictive value. So the negative predictive value is very high. So you should be reassured that if I get a negative result, it's most
Mm.
likely
Right.
a negative result. But if you get a positive result, then you really need to go for a test with the medical testing laboratory that has clinical scientists or clinical oversight that are able to explain your result after having the test and what are the next steps and are able to manage your expectations. I hope I've answered your question, Ella.
Thank you so much indeed. That was a thoroughly answered question for sure. And thank you for your question, Ella. Let's have a look. Next question is up. So detection of trisomy 13 in non-invasive study in a blood in a pregnancy of 10 weeks, what percentage in your experience is reflection or reality?
Uh, so I think what Sergio is asking is if you get a uh, if you get a trisomy 13 result at 10 weeks, a positive result, what's the positive predictive value? Again,
Mm-hmm.
I think
Yeah.
what is it a true or a false positive
Yes.
result? Again, Sergio, you need to
Yes.
take into consideration the sensitivity, specificity of the test, and then the age. Yes, perfect. And then the age of the patient. It's very important, the age of the
Mm-hmm.
patient. Okay, it's similar to trisomy 21. Now, the positive predictive value for trisomies 18 and 21 are slightly lower than, sorry, for trisomies 18 and 13 are lower than trisomies 21. But the same principle applies there.
Okay. Thank you so much, Sergio, for your question here. Let's have a look. More questions are up. Could you please clarify increased maternal age for IVF? Is this the age when the egg cells were collected and embryo were frozen, or the age of the embryo transfer?
It is the age when the eggs were collected and embryo was created,
Yeah,
not the embryo transfer.
yeah, thank
But
you so
good
much
question, yes.
for the clarification. True, useful to remember that. Lovely presentation. What is your opinion regarding offering NIPT in IVF+PGT-A pregnancies where a mosaic embryo was actually transferred?
Miguel, hi Miguel. Very good question. Very good question. Well, if you have PGTA and you have a mosaic result, it's still problematic, because patients are, oh, should I really, even after counseling, should I really transfer the mosaic embryo? Shall I not? And most of the times, these embryos get either frozen or discarded, which is unfortunate. But now we have a possibility to do expanded NIPT, and it is like a second check for the PGTA test and gives more reassurance to the patient. So the patient, if I had, if I had only this one mosaic embryo, let's say, would transfer this embryo, but opt for an expanded NIPT that will give you an idea whether this mosaicism has persisted, and if the results are concordant with PGTA, it means that okay, this might be a true result. Then at the end, you need to do invasive. Very good question, Miguel.
Thank you so much indeed. And actually, next question is regarding the expanded version of NIPT. So there are various types. The basic one looks for the three trisomies. Expanded ones, which look at greater range of rare diseases. Are the rare diseases common enough to make the expanded test worth it?
Um, yes, there are, as I said, basic. There's the expanded NIPT that we just talked about, but there are other more advanced NIPT that not only look at the chromosomal abnormalities, but at something called monogenic disorders, or just like you know, and some of these monogenic disorders could be rare diseases. There are certain companies, such as Eurofins, my company, we offer this, very very advanced test. Now, is it worth it or not? That's a very 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 difficult question to answer. You need to definitely have a pre-consultation, and speak to a person, from our laboratory. We arrange that to go through the specifics of the test. What do you expect? Which disorders are screened for? If you get a positive result, what do you expect? How many of your positive results have been confirmed later? Look at the internal data of the laboratory. Ask about concordance. Ask about discordance, and then have this pre-consultation. And if you have, in the unlikely event, these are rare diseases. In the unlikely event you have a positive result for these rare diseases, you need to go for genetic counseling to manage,
Mhm.
the expectations, to discuss the next steps. As long as you are properly counseled and aware what the test screens for, what's the concordance and discordance based on the internal data of the laboratory, then yes, this test might be worth it.
Okay. Thank you, Nicola, for your question. Interesting one for sure as well. There are more questions, two of those. So if you have more, you know what to do, type this in. And let's have a look. The next question is, so if a lab offers blood collection any day, but the NIPT test is a few days later, does this affect the result?
That's a very good question. So NIPT is collected in a very specialized tube called the Streck tube, and this Streck tube stabilizes the the blood, or the material needed for NIPT, for 5 days, and it's been validated for 5 days. So make sure that after taking blood in this tube, the laboratory needs to receive it at a latest 5 days after.
Crystal clear. Thank you so much for your question indeed. Possibly our final question. So, as I mentioned, if you have more questions, this will be the final call for those. Okay, so don't hesitate. We still have time for you. And the question is, if you can clarify, right? So, sorry if this is repetitive, but can you please explain the significance of PPV in relation to considering having the test or not? Like in that study where 87% were false positive.
Yes, PPV is the most important thing you need to look at after you've done your NIPT and you've received a screen positive result. You need to ask the laboratory, based on your internal data and your test, what is the PPV for this trisomy? Okay. Now you can calculate. It usually laboratories have ranges, or they give you an average, and they can even calculate it based on your age or the age of the female patient. So you need to ask the laboratory, and the laboratory will have the question, will have the answer. Um, if you're opting for an NIPT test, and ask the question to the laboratory before going for the test, are you able to calculate my PPV after the test? If the laboratory says no, we will just issue a result, I wouldn't recommend going with that laboratory.
Mm. That makes sense, of course. Thank you so much for your question as well. And Roy, thank you so much for answering this and all our previous questions. It seems that that was our final question, but thank you so much, everyone, for joining. I do believe it was a very interesting session with lots of. It's a difficult topic for sure as well. So thank you so much for joining us. Someone is typing. I just want to make sure we answered all of your questions. But remember, if you wish to get in touch with Roy and his team at Eurofins, I'm sure they will be happy to take more questions from you. So don't hesitate. There will be a time and option for you to ask. And I believe we will be finishing for today. But before we actually finish, Roy, anything else you wish to add?
No, thank you, Caroline, for this opportunity, and it's always a pleasure to present something useful for patients, especially
Definitely.
in these topics that could be misleading to certain patients.
Definitely,
Yeah.
indeed. So thank you so much indeed for joining. I also want to add that we will be back next week. We will talk about the advantages of comprehensive chromosome screening, PGTA, CCS. So if this is something that you are thinking about, or this is something that you have some questions about, so you can join us, and we'll be happy to again help you out with any questions that you might have. And Dr. Natalia Polipenko will be with us as well. This is next Tuesday, so join us. You can sign up on our website. And also, I always want to ask you, so remember that if you wish to share what kind of topics you wish for us to discuss, I know you have some ideas for sure. So if this is something that if there is any topic that you would like us to discuss, please just type this in the chat, or you can simply email me at Caroline at EuropeanFertilitySociety.com. We'll be happy to take your ideas and, of course, things that you need. We are definitely here for you. You can also send us your feedback. I only can encourage you to do this, but we definitely want to know what you think, what you want for us to discuss. As you know, we are preparing for the next year topics, so feel free to do it. We are definitely interested to hear from you. And remember, this has been recorded, so if anyone missed any parts of this webinar, don't worry, it will be available on our website. Roy, thank you so much for joining us today. It's been great to have you for sure. Looking forward to some more events and some new topics with you as well. Take care. Have a
Thank you,
good evening.
Caroline. You
Have a good
too.
evening, everyone, and
Thank
see
you,
you
everyone.
soon as well.
Bye
Take care.
bye.
Bye.